It's very early in the morning and probably you're all sleeping, but because usually at 8 o'clock you are all sleeping. So I decided to record this lecture for you so you could listen to it and watch it at your convenience. Today, we're going to speak about parathyroid disorders. And when we speak about parathyroid disorders, we are referring to primary hyperparathyroidism, secondary hyperparathyroidism, and tertiary hyperparathyroidism. The parathyroid glands are the last human organs to be discovered. These glands were discovered in the Indian rhinoceros by Owen, and therefore these are known as the glands of Owen. And you can find the specimen in which the parathyroid glands were discovered in the British Museum of the Royal Surgical College. It's important to know that the parathyroid glands or calcium homeostasis in general is controlled by three hormones, which are the parathyroid glands, vitamin D, and calcitonin. And therefore, it's important to know how each of these hormones contributes to calcium homeostasis. We all know that diet is a very, very limited or deficient source of vitamin. However, a major source of vitamin D is solar irradiation of the skin, which converts 7-dehydrocholesterol in the skin into the active form of vitamin D, which is known as vitamin D3 or cholecalciferol. Cholecalciferol or vitamin D3 is then subject to two phases of activation. The first is in the liver, where it undergoes its first hydroxylation and is converted into 25-hydroxy-cholecalciferol or 25-hydroxy vitamin D3. And then in the kidney, it is converted into 125-dihydroxy-cholecalciferol or dihydroxy vitamin D3, which is the final and active form of vitamin D3. Note, so we have two hydroxylation processes. The first is in the liver and the second is in the kidney. And the hydroxylation in the kidney produces the final and active product of vitamin D3, which is 125-hydroxy-cholecalciferol. Notice that the enzyme that is responsible for the hydroxylation of vitamin D3 in the kidney is known as renal 1 alpha hydroxylase. So this is a very important enzyme for the production of the final active form of vitamin D3. And the catalyst for this enzyme is the parathyroid hormone. So the parathyroid hormone is a major contributor for the formation of the final and active form of vitamin D3, which is known as 125-dihydroxy-cholecalciferol. As we can see, that vitamin D3 or active vitamin D3's main role is to increase the absorption of dietary calcium from the intestine, and therefore any deficiency in vitamin D3 or its active form means that you will have a deficiency in calcium. And this is why we should always remember that one of the major causes for secondary hyperparathyroidism is vitamin D deficiency. We will elaborate further on. Notice here, this figure demonstrates how 3 hormones contribute to calcium homeostasis. The first is the active form of vitamin D3, which is 1,25-dihydroxycholecalciferol, the parathyroid hormone, and calcitonin. As for the parathyroid hormones or hormone, we should know that the parathyroid glands are the only endocrine glands that are not controlled by the hypothalamic pituitary axis as in other endocrine glands. What we mean by that is that, let's take the thyroid, for example, or the adrenal gland, for example. We know that the thyroid gland is controlled by the hypothalamic pituitary axis. The anterior pituitary responds to the hypothalamus by releasing TSH, and the TSH in turn stimulates the production and the release of thyroid hormones. Again, if you take the adrenal, for example, the anterior pituitary responds to the hypothalamus by releasing the ACTH, which in turn stimulates the adrenal cortex to produce and release its hormones. The parathyroid glands are not controlled by the hypothalamic pituitary axis. What controls parathyroid hormone secretion is ionized serum calcium levels. So if ionized serum calcium levels go down, then parathyroid glands are stimulated and start secreting. And if the ionized serum calcium levels go up, then the parathyroid glands are suppressed and they do not secrete. So the only endocrine gland that is not related, that is out of the control of the hypothalamic pituitary axis, are the parathyroid glands. It is mainly controlled through ionized serum calcium levels. And why we say ionized serum calcium levels, it is because it is the ionized form of calcium which is the form of calcium. Other forms of calcium are either albumin bound or bound to anions and therefore are inactive. Calcitonin, again, is a major regulator of calcium, so it interferes with calcium homeostasis. And as we all know that the calcitonin is secreted by the C cells in the thyroid gland or the parafollicular cells in the thyroid gland. And it has a role that is opposite to that of the parathyroid hormone. So let us move on. So if you look at this figure where it integrates how calcium hemostasis is taking place. Again, look at the right side of the figure. Remember that we have three forms of calcium. We know that 40% of calcium is bound to albumin and therefore it is inactive. 10% of calcium is bound to anions like citrate and phosphate and is therefore inactive. So in sum, 50% of calcium is present in a bound form and therefore it is present in an inactive form, whereas only 50% of calcium is free or ionized, and this is the active form of calcium that regulates parathyroid hormone secretion. So if you see in the figure, when ionized serum calcium levels go down, then this will stimulate the four parathyroid glands to release the parathyroid hormone. Notice that the parathyroid hormone affects bones and increases calcium and phosphorus resorption. So it takes off calcium and phosphate from bones to elevate the serum concentrations of calcium. It goes to the kidneys, and as we said earlier, it is the catalyst for the second hydroxylation of vitamin D3. So it starts catalyzing or stimulating renal 1-alpha hydroxylase to produce more of 1,25-dihydroxycholecalciferol, which is the active form of vitamin D3, to increase the absorption of calcium and phosphorus. So see how all this is beautifully related. Okay, here I want you to stop and think of the following. When we say a person has hyperparathyroidism, so he has elevated levels of parathyroid hormone in the blood. Mainly, this could be primary or secondary. What do we mean by primary hyperparathyroidism? We mean that the problem is primarily in one or more of the parathyroid glands. We either have a parathyroid adenoma secreting autonomously parathyroid hormones, or we have two parathyroid adenomas autonomously secreting parathyroid hormones, or we might have four glands being hyperplastic and autonomously secreting the parathyroid hormones. Autonomous secretion means secreting independently, out of control, بشكل مستقل. طيب, this is the first type of hyperparathyroidism, primary hyperparathyroidism. What do we mean by secondary hyperparathyroidism? Is that the parathyroid glands are over-secreting their product, which is the parathyroid hormone, secondary to some problem that has caused calcium deficiency. And from this figure, we can easily conclude that the two major causes for Low levels of serum calcium are vitamin D deficiency, because if vitamin D is deficient, then there would be no proper absorption of calcium from the intestine, or renal failure, chronic kidney disease, because if the kidney is diseased, then its enzyme, which is the alpha-1 hydroxylase, would not be able to hydroxylize or perform the second hydroxylation of vitamin D3 and produce the active form of vitamin D3. So the two major causes of secondary hyperparathyroidism are renal failure and vitamin D deficiency. How could we differentiate biochemically between primary hyperparathyroidism and secondary hyperparathyroidism? In primary hyperparathyroidism, the parathyroid gland itself is autonomous. So it is autonomously releasing its product in excess. And it has nothing to do with any calcium deficiency in blood. And therefore, what would happen is that you see the parathyroid hormone levels are high, and this is paralleled by also elevated serum calcium levels. However, in secondary hyperparathyroidism, we know that the excess release of parathyroid gland is a compensatory mechanism. It is secondary to some factor that has led to a decrease or drop in serum calcium level. And as a compensatory means, the parathyroid glands are excessively secreting a parathyroid hormone to compensate for the deficiency in serum calcium levels. So the parathyroid hormone levels would be high. However, the calcium levels would either be low or normal. So لاحظ, primary hyperparathyroidism, both PTH and calcium are elevated. In secondary hyperparathyroidism, serum calcium levels would be either normal or low, and the PTH would be elevated. So this is حقيقة simple if you understand calcium homeostasis. Again, in this figure, we have emphasized that the parathyroid glands are unlike other endocrine glands. They are not controlled by the hypothalamic pituitary axis. They are only controlled by the active form of calcium, which is the ionized serum calcium levels. The ionized serum calcium has G receptors by which it acts on the parathyroid glands. So this figure again demonstrates a calcium feedback on the parathyroid glands. This table summarizes the effect of the parathyroid gland, the parathyroid hormone, the active form of vitamin D3, which here is written as calcitrol, and calcitonin on calcium homeostasis. So we have mentioned earlier that hyperparathyroidism could be primary, could be secondary, and we have discussed in primary and secondary hyperparathyroidism, and it could also be tertiary. Let's speak about primary again. We said that the cause of primary hyperparathyroidism is primarily related to one or more of the parathyroid glands, by which I mean that you can have single gland disease, a single adenoma, which is in fact or accounts for 90% of cases of primary hyperparathyroidism. You have a single gland that has an adenoma that is secreting a parathyroid hormone in excess, and 99% of parathyroid adenomas tend to be benign, and only 1% tend to be malignant. And remember that a benign parathyroid adenoma could never be palpable as a neck mass. However, the much more aggressive parathyroid carcinoma, which accounts for only 1% of cases of primary hyperparathyroidism, could be appreciated as a palpable neck mass. We can have double adenomas, what we call two parathyroid adenomas secreting a PTH. This is called double adenomas or two gland disease. Or alternatively, we might have parathyroid hyperplasia, by which we mean the four gland disease. The four glands are hyperplastic and secreting their product in excess. And usually this is haqiqatan seen in MEN1, the 3P syndrome, or MEN2A, which is known as the pheochromocytoma medullary carcinoma syndrome with primary hyperparathyroidism. Or we can also see it with what we call the hyperparathyroid jaw tumor syndrome. So these are the main conditions in which you see four gland disease or parathyroid hyperplasia. Again, secondary hyperparathyroidism, as we mentioned earlier, is due to some cause of hypocalcemia. Mainly, or the most common cause of hypocalcemia is renal failure. Well, there are two interpretations for why renal failure produces hypocalcemia. One, when the kidney is impaired, then its enzyme, which is renal 1-alpha hydroxylase, is impaired or deficient, and therefore the production of the active form of vitamin D3 is deficient. Secondly, in renal failure, we have decreased absorption of phosphate, and therefore phosphate accumulates in blood, producing hyperphosphatemia. Phosphate is an anion, and anions bind to calcium, and any form of calcium that is bound is inactive. So the inactive form of calcium decreases, causing a state of hypocalcemia. The second most common cause of secondary hyperparathyroidism is vitamin D deficiency. Okay, what do we mean by tertiary hyperparathyroidism? حقيقة, the typical scenario of tertiary hyperparathyroidism is as such. You have a patient with chronic renal failure who has secondary hyperparathyroidism due to diseased kidney, which fails to produce the active form of vitamin D3 and binds the active form of calcium through accumulated phosphate in blood. And this patient finds a donor and undergoes a renal transplant. So after renal transplant, you expect that the situation would be solved because you have a good kidney. Yes, indeed, this is what happens in the vast majority of patients, and the condition is corrected. However, in 3% of patients who undergo renal transplant, the parathyroid glands who were over-secreting due to the secondary hyperparathyroidism, they become autonomous and they continue to over-secrete autonomously in this patient. So this is called tertiary hyperparathyroidism. So you have high levels of PTH, high levels of calcium, because we have no reason for PTH elevation because of calcium deficiency. We have a new kidney that is functioning well, but the problem is that the glands which used to secrete because of calcium deficiency have become autonomous. And the major clue in the history that your patient had secondary hyperparathyroidism due to renal failure, and he has now received a kidney. This table summarizes حقيقة the biochemical profile in primary hyperparathyroidism and secondary hyperparathyroidism. Notice that the most important thing is to differentiate biochemically between primary hyperparathyroidism and secondary hyperparathyroidism. So, how do patients with primary hyperparathyroidism present? These patients usually present with painful bones, renal stones, abdominal groans, psychic moans, and fatigue overtones. What do we mean by that? لاحظ حقيقة إنه spectrum of bone manifestations due to hyperparathyroidism حقيقة ranges from bone pain and then goes to osteopenia, osteoporosis, then osteitis fibrosa cystica, and pathologic fractures. So this is the whole spectrum of bone disease in primary hyperparathyroidism. Then renal stones حقيقة, and it's important to know the most common form of renal stones in these patients are also calcium oxalate, not calcium phosphate stones. Abdominal groans, they tend to present with epigastric pain. Why epigastric pain? Because elevated PTH level increases the basal gastric acid secretion, and this leads to the manifestations similar to that of peptic ulcer disease. Constipation due to hypercalcemia, fatigue, depression, and anxiety are the main psychiatric manifestations of primary hyperparathyroidism. And of course, over excitability of reflexes. Nevertheless, remember that the most common manifestation of primary hyperparathyroidism is being asymptomatic. So kindly go through this table and that for their major importance. Now, your patient presents with primary hyperparathyroidism. He has elevated PTH levels, elevated serum calcium levels, and therefore you have a case of primary hyperparathyroidism. The next step you have to do, حقيقة, in modern medicine is to localize your diseased gland. احنا حكينا انه 90% من الحالات are due to single gland disease or a single adenoma. So the first thing you need to do is to localize your diseased gland. You begin by a simple imaging study, and then you move on to a more sensitive study. The first study حقيقة is what we call an ultrasound. Now, ultrasound has a sensitivity of 63%, okay? And if you localize a parathyroid adenoma by ultrasound alone, then حقيقة you have a 90% chance that this is the only gland that is diseased. If you do a system-EB scan or a MEB scan alone, you have a higher sensitivity, which is 69%, or let's say 70%. And if you localize a single gland, then حقيقة you have also a 90% chance that this is the only gland that is positive. This is why we prefer to increase the positive predictive value of the study by performing both ultrasound and MEB. And if you have concordant localization, then this يعني both مثلا point to the, let's say, right inferior parathyroid gland, then you have a 99% chance, almost 100% chance that this is the only gland to be involved. يعني إذا عملت ultrasound لحاله صحيح الحساسية عالية و89% أو 90% إنه هاي هي الجلاند المطلوبة، ولكن في عنا 10% ممكن يكون في عندهم دبل أدينوما. عملنا سيستانيبي لحالها برضو نفس الإشي، ورجتنا جلاند واحدة، لسه في 10% احتمال إنه يكون في عنا جلاند أخرى ما بينت. ولكن إذا عملنا الثنتين والثنتين أشاروا على نفس الجار درقية، معناته إحنا تقريبا 100% وصلنا إلى الجلاند المطلوبة، ومش راح يكون في عنا another adenoma. This is why we prefer dual localization. هلا بما إنه إحنا we have properly localized the diseased gland, then we can يا إخوان go and operate. هلا, do we need to go explore the four glands when we have dual localization? No. We go and remove the gland that we have localized immediately. So we perform what we call targeted parathyroid surgery, or alternatively, it is called minimally invasive parathyroid surgery. هلا, once you remove the gland, you do not conclude the operation. ليش؟ لأنه you have to prove that your operation is successful. وبالتالي, once you remove the gland, you wait for 5 minutes, which is the half-life of the parathyroid hormone, and you measure the parathyroid hormone levels intraoperatively while your patient is still anesthetized. So, let's say that preoperatively the parathyroid hormone was 100, واحنا بنعرف انه النورمال parathyroid hormone level لازم يكون بين ال 15 وال 65. The parathyroid hormone 5 minutes after removal of the gland should drop by 50% or more and fall within the normal range. وبالتالي لازم يصير عندنا الباراثايرويد هرمون نورمال إذا كانت الجلاند المشيولة هي الجلاند الصحيحة. So, وجود good localization studies والability to measure the parathyroid hormone intraoperatively مكننا من القيام بما يسمى targeted or minimally invasive parathyroid surgery على عكس السابق، بحيث انه ما كان في هاي الامكانيات لا انه نعمل advanced imaging studies ولا انه نقيس الباراثايرويد هرمون ليفل intraoperatively. وبالتالي كان الجراح يعمل full neck exploration، يفتح على الأربعة parathyroid glands ويتفرج عليهم الأربعة، الكبيرة منهم يشيلها. ولكن طبعا الفاعلية للطريقتين متساويات، ولكن التارجتد أو المينيمالي انفيزيف سيرجري فيها دايسكشن أقل، احتمال يصير في عندنا مضاعفات أقل لأنه التشريح محدود للرقبة، تمام، وبالتالي الزمن الجراحي راح يكون أقل، الوجع راح يكون أقل، والحاجة إلى برابيش أقل، والرجوع إلى المنزل بوقت مبكر كذلك أفضل. ولهذا التطور العلمي دائما مفيد للمريض. طيب، افرض إجاك حدا عنده primary hyperparathyroidism، وكما يعني تحدثنا سابقا حكينا إنه the most common manifestation of primary hyperparathyroidism is being asymptomatic. فحقيقة هناك indications for surgery in asymptomatic patients with primary hyperparathyroidism. And these are the latest, which were stated in the 4th International Workshop of the European Society of Endocrine Surgeons in 2014. لاحظ دائما مهم جدا إذا لقينا أن السيرم كالسيوم ليفل أعلى على الأقل ب1 ملغرام per deciliter أو 0.25 millimole per liter than in normal. So this is considered significant and an indication for surgery. إذا كان عمر المريض أقل من 50 عام, and again this is an indication because the patient will have enough time to develop symptoms. إذا كان في عنا التي سكور، يعني إذا عملنا بون دنسومتري ولقينا التي سكور وهو سكور للهشاشة كان أقل من -2.5، تمام، بأي منطقة في العظم، سواء كان العمود الفقري، سواء كان في الكوع أو الألبو، أو سواء كان في الإجر، أقل من -2.5، هذا indication for surgery. إذا كان في عنا any fractures, pathologic fractures, then this is again an indication for surgery. إذا كان في عنا glomerular filtration rate أقل من 60 ml per minute, an indication for surgery. إذا كان في عنا renal stone سواء كان على KUB or على CT renal protocol or ultrasound, then this is again an indication for surgery. إذا كان عندنا urinary calcium more than 10, this is again an indication for surgery. هلا حقيقة 24-hour urine collection and measuring calcium used to be حقيقة indicated in the 3rd international workshop, but it is no more. All right, guys. This here, this figure, Bismillah. This figure, حقيقة, summarizes how to surgically approach patients with primary hyperparathyroidism. This summarizes what we have mentioned earlier. والله يعطيكم العافية، وإن شاء الله كان هذا very useful لكم، ونلقاكم في المرات القادمة.